Today we're going to cover Chapter 11, Community Mental Health. Mental illness is one of the major health issues facing every community. It is the leading cause of disability in North America and Europe, and it costs the United States more than $500 billion per year in treatment and other expenses. About 20% of American adults have a diagnosable mental disorder during any given year, and about 5% of these adults have a serious mental illness. However, only 38% actually receive treatment for their mental illness. So mental disorders reduce average life expectancy, and in some cases involving substance use disorders, anorexia, schizophrenia, or bipolar mood disorder, it reduces life expectancy by the same amount as does smoking more than 20 cigarettes a day. And mental disorders are associated with smoking, reduced activity, poor diet, obesity, hypertension, and also contribute to unintentional and intentional injury. The needs of people with mental illnesses are very diverse. So services range from therapeutic services and social services, or range to social services. Here we have an image of causes of disability for all ages combined within the United States, Canada, and Western Europe for the year 2000. Some of the causes include Alzheimer's disease and other dementias, respiratory diseases, cardiovascular diseases, injuries, digestive issues, communicable diseases, etc. And on the very bottom we have all other causes. Almost half of college students show a 12-month prevalence of some form of mental disorder. Most often this is alcohol use disorder at 20% of college students, and less than a quarter of these students receive treatment. In the year 2010, 2.9 million youths, or 12% of those aged 12 to 17, received treatment or counseling for problems with emotions or behavior in a specialty mental health setting. This could be inpatient or outpatient care. Here is a table of 12-month prevalence. Remember, prevalence is the amount of people in a population with whatever we're talking about. So 12-month prevalence of mental disorders in college students and non-college attending peers aged 18 to 25. So for someone to have any psychiatric diagnosis, about 45% of those in college reported it, and 47% of those not in college reported it. Any alcohol use disorder, 20% in college, 16% not in college, so it is higher in college here. Drug use disorder is higher when you're not in college, etc. So you can read through these to see if there are any differences between those in college and not in college. Now we're going to go over some definitions. First one is mental health. And mental health is a state of successful performance of mental function, resulting in productive activities, fulfilling relationships with other people, and the ability to adapt to change and to cope with adversity. Adversity is a synonym for problems or obstacles. Mental illness is a term that refers collectively to all diagnosable mental disorders. Mental disorders are health conditions that are characterized by alterations in thinking, mood, or behavior, or some combination thereof. And it's associated with distress, and or impaired functioning. People with mental illness have neurobiological disorders that prevent them from functioning effectively and happily in society. Many people with mental illness can be treated with medications and other forms of help, and thus are able to adapt successfully to community life. Adults with good mental health are able to function under adversity or function under stress or challenges, change or adapt to changes around them, maintain control over their tension and anxiety, find more satisfaction in giving than receiving, show consideration for others, curb hate and guilt, and love others. Next, we're going to talk about how you classify mental disorders. And the means by which we do this is through the Diagnostic and Statistical Manual of Mental Disorders. This is abbreviated the DSM. and you'll hear it referred to as the DSM. So right now we're in the 5th edition, meaning they've made 5 different editions of it. It's progressing over time, and it's published by the American Psychiatric Association. It is one of the most influential books in mental health, probably the most influential book, and it classifies disorders based on behavioral science and symptoms. So instead of defining something by a test or measurement of the brain or another body system, it classifies mental disorders by their symptoms. So some of the challenges to diagnosis include comorbidity and lack of cultural competence. So if someone has another disability or another illness that is interfering with their mental illness, it can make it hard to diagnose. And we'll talk about cultural competence coming up. Here we have a table of major diagnostic categories of mental disorders. So you can see on the left that there are quite a few different categories. We have personality disorders, sexual dysfunctions, feeding and eating disorders, dissociative disorders, anxiety disorders, depressive disorders, etc. And on the right you can see some examples of these types of disorders. Sorry about that. So lack of cultural competence, such as language proficiency, familiarity with cultural idioms of distress or body language, may lead to a diagnostician to misinterpret as depression what is simply a Hispanic patient's subdued and discouraged demeanor and reluctance to disclose symptoms. Okay, so as an individual, so if I am diagnosing someone and I'm not familiar with like Hispanic norms or Hispanic body language or what they consider stigmatized, right, I might think they're acting depressed or exhibiting symptoms of depression when in reality that's just their culture. So the social context can also affect diagnosis. Worldwide, for example, women are diagnosed with mood disorders more often than are men, but this difference is smaller in countries that have less traditional gender role differences in employment opportunities, educational attainment, and control of fertility. The symptoms can arise from various causes, and this can cause a mental disorder. So some of the common causes are poor prenatal care, postnatal environment, genetics, environmental factors, brain function impairment, substance abuse, maladaptive family functioning, or stress. PTSD, or post-traumatic stress disorder, can also cause mental disorders. So clearly stress is a significant cause of mental illness. For example, people who survive disasters and soldiers returning from combat face an increased risk of developing a mental disorder. The brain is very sensitive to stress and other environmental influences as it develops during childhood and adolescence. In any given year, up to 1 in 5 children experiences a mental disorder, yet less than half of children and adolescents who need mental health services actually receive them. Lifelong mental disorders often have their onset in adolescence, when physical and hormonal changes intensify emotional reactivity, sensitivity to peer influence, impulsivity, and novelty seeking, undermining the self-control and regulation needed for effective participation in society. Mental disorders reflect not just biological vulnerability, but also stress, social support, coping, and motivation to recover, making social experience a direct determinant of who gets a mental illness and how the illness unfolds. Some children face considerable adversity, including poverty, abuse, loss, neglect, trauma, and parental psychiatric disorder. So just for example, every year about 10% of children are physically or sexually abused. And again, this puts you at a higher risk of developing a disorder. Next, we're going to talk about stress as a contemporary mental health problem. So as we know, stress is a psychological and physiological response to stressors. Right? So we respond mentally and we respond physically. Now, a stressor can be anything that causes a stressful response. And stress is a positive thing, right? Stress encourages us to take initiative, to do things. If we had zero stress our whole lives, we would not do anything. Stress can be good, but it can become too much to bear. So one of the things that we need to define is the general adaptation syndrome. And this suggests that we respond to stressors in 3 stages, and you can see on the figure on the right. The first stage is an alarm reaction. Second stage is a stage of resistance, and the third stage is exhaustion. So in the alarm stage, various hormonal changes in the body increase the individual's heart rate, respiration, breathing, and blood pressure. This is the fight or flight reaction that you've probably heard of. A response that the body cannot maintain for very long, right? So we get frightened somehow, right? We're stressed out, our heart rate increases, and we decide to either, right, go towards the stressor, literally fight it or address it, right? Start doing our homework that's stressing us out, or we flight and we run away, we ignore it. So the continued challenge by the stressor leads to resistance, where the body tries to adapt to the stress. Physiological arousal declines and the body begins to replenish the hormones released in the alarm stage, but the ability to cope with the new stressor is impaired. As a result, the person is vulnerable to certain health problems that are referred to as diseases of adaptation. This includes ulcers, high blood pressure, coronary heart disease, asthma, and impaired immune function. You might have noticed before that during the very beginning of school, midterms, and exams, people tend to get more sick, and this is often due to the increase in stress and the decrease in immune function. And then the third stage, prolonged physiologic arousal produced by continual or repeated stress, depletes energy to the point of exhaustion. During that stage, physiological damage, physical diseases, mental health problems, and even death can occur. So experts recommend a combination of physical, social, and environmental and psychological approaches to managing stress. So we need to approach stress from a holistic viewpoint. Among middle-aged white Americans, especially those with a high school education or less, suicide and substance abuse led to an unexpected rise in death rates between 1999 and 2014. One of the objectives of Healthy People 2020, which we've discussed in class before, actually aimed at improving the mental health status of Americans in order to reduce the overall suicide rate. The prevalence of alcohol and other drug abuse is a social indicator of mental illness problems. For example, in 2002, 40% of college-aged young adults and 28% of high school seniors interviewed had drunk at least 5 or more drinks in a row in the previous 2 weeks. And 25% of 12th graders reported using an illegal drug in the previous 30 days. So now we're going to go over a brief history of mental health care in the United States. And the response to mental illness is characterized by periods of enthusiastic reform, right? We're motivated, we're going to change and improve things, followed by periods of widespread ambivalence, or widespread lack of progress. So in colonial America, before World War II, people with mental illness were cared for by families or private caretakers. Institutionalization for people with mental illnesses first appeared in the 18th century, and the population growth led to institution growth. Right? We had more institutions, they were getting bigger, more people were going into them. However, this resulted in some harsh treatments and unpleasant living conditions. The moral treatment era began in 1792, and this was the belief that the environmental changes can affect the mind and alter behavior. So we moved people from settings causing life stressors into rural, peaceful settings. And this appeared to have success and became widely acceptable. However, there was eventual overcrowding due to population growth, so it's not sustainable long term. The state mental hospitals were supposed to supply an environment in which therapeutic care was based on close personal relationships between patients and well-trained staff members, as prescribed in the methods of moral treatment. Unfortunately, the chronic nature of mental illness made long-term or even lifetime hospital stays increasingly the norm. Maximum capacities were quickly reached, exceeded, and repeatedly revised upward. Personalized care became impractical, and physical restraints provided the most efficient way to manage patients on large wards. States repeatedly cut funding for these institutions until all that remained was custodial care by an overworked staff that turned over frequently. So this deterioration of services occurred during this entire time. In 1940, the population in state mental institutions was nearly 500,000 individuals. Staff caseloads were so large that only subsistence care was possible. So one of these cares was electroconvulsive therapy, or ECT. Lobotomies were also practiced, and lobotomy is a surgical severance or cutting of nerve fibers in the brain by incision. And the appearance of new medications in the 1950s made lobotomies unnecessary. After World War II, the National Institute of Mental Health, or the NIMH, was established. This is the nation's leading mental health research agency, housed within the National Institute of Health. Their aim was to foster and aid research related to cause, diagnosis, and treatment of neuropsychiatric disorders, to provide training and award fellowships and grants for work in mental health, and to aid states in the prevention, diagnosis, and treatment of neuropsychiatric disorders. Deinstitutionalization is the discharging of thousands of patients from state mental hospitals. This is propelled by economics, idealism, legal considerations, and antipsychotic drugs. So now that we had more options, we could get people out of institutions and they could be treated from home. Here we have a graph of the number of resident patients in state and county mental hospitals at the end of the year, from 1950 to 1994. And you can see that there was a sharp decrease that occurred in the 60s. In 1963, mental illness and its treatment gained national attention when President John F. Kennedy addressed Congress on the subject of mental health care. The resulting Mental Retardation Facilities and Community Mental Health Centers Act promised funding to establish one fully staffed, full-time community mental health center in each of the 1,500 designated catchment areas covering the entire United States. So these community mental health centers had 5 core services, and their services included inpatient care, outpatient services, 24-hour-a-day emergency care, day treatment or other partial hospitalization services, and consultation and education. Oops. Mental illness and violence. Extreme violence is relatively rare in people with mental disorders. Much of this risk is attributable to comorbid factors. So what should be done to prevent violence is unclear, as there are constitutional issues related to individual freedoms, privacy, and other rights. So legally, authorities can act to prevent potential violence only when someone voluntarily seeks assistance or has made frank threats. People with serious mental illness are marginalized individuals who, for the most part, are unemployed, economically impoverished, live in disadvantaged neighborhoods, often misuse alcohol and illicit drugs, and are regularly victimized or even traumatized. Most violent behavior is due to factors like these rather than to mental illness. Although psychiatric disorders such as depression are strongly implicated in suicide, which accounts for over half of U.S. firearm-related fatalities. Mental health care in jails and prisons. Rates of serious mental illness in the U.S. correctional facilities are 3 to 4 times the rates in the general population, meaning people in jails and prisons have 3 to 4 times more mental illness than those outside of jails and prisons. So correctional facilities are designed to confine and punish, not to treat diseases. Okay? They have a lack of space, lack of adequate number of qualified treatment personnel, and lack of timely access to services. Individuals with criminal involvement and serious mental illness who do not receive treatment are more likely to commit another offense than are justice-involved people without mental disorders. While they constitute a small proportion of people with mental illness, these individuals often resist participating in treatment and may pose a danger to himself or herself or the public, resulting in frequent psychiatric hospitalizations. So one of the ways people are trying to prevent this is by creating a crisis intervention team. And these are specially trained police in direct collaboration with mental health authorities that help remove barriers to mental health care for people with mental illness involved in the justice system. So it is a legal and moral obligation to provide cost-effective prevention, treatment, and rehabilitation services to people with mental illness. And this is an important challenge facing every community today. So first we have primary prevention, and we've gone through this before, but we're going to go over it again. So in terms of primary prevention, we want to reduce the incidence, right? We want to reduce the number of cases of mental illness and related issues. Now to do this, we'll have to encompass a lot of issues. We need to make sure people are handling stress, we're avoiding trauma, we're making sure everybody's safe. Secondary prevention reduces the prevalence by shortening the duration of episodes. So at this point, someone already has a mental illness, but we are trying to help them cope with it. And then lastly is tertiary prevention, and this is treatment and rehabilitation. So there are different treatment approaches, and the goals of treatment of mental disorders include to reduce symptoms, improve personal and social functioning, to develop and strengthen coping skills, and to promote behaviors that make a person's life better. Psychopharmacology. Psychopharmacology therapy is treatment with medications, right, using prescription drugs. Conditions for which medications exist include schizophrenia, bipolar disorder, major depression, anxiety, panic disorder, and obsessive-compulsive disorder. Other biomedical therapy includes ECT, which we mentioned earlier. Another type of treatment is psychotherapy, and this is most likely what you imagine when you think of therapy, talking to a therapist. So it's treatment through verbal communication. And there are many different approaches you can take within psychotherapy, such as cognitive behavioral therapy. Psychotherapy is more likely to be successful in less severe cases or when used in conjunction with other approaches as well. Technology can also be very vital to the treatment process. So use of technology in treatment via telephone, video conferencing, internet, email, or computer software has direct benefits, and it delivers flexible help directly to clients' living environments. It lowers costs to patients and increases privacy of the patient, and it may reduce feelings of coerciveness. Another type is self-help groups. Self-help groups are concerned members of the community who are united by a shared interest, concern, or deficit not shared by other members of the community. So you could be in a self-help group that's made up of other people with the same mental illness or that share similar issues, right? And then we also have the National Alliance on Mental Illness, which is formed to help people join these groups. Next, we have psychiatric rehabilitation. The primary objective is most often recovery rather than cure. So some services include medication, therapy, adaptive skills, changing environment through accommodations at work or school, but these practices must be evidence-based, meaning we have research to demonstrate that they are effective. Some of the challenges facing mental health care in the United States. So multiple services are needed. We really need to address mental health care at every single angle. Okay, there are a lot of different services. It's not just simply psychotherapy or just talking to a therapist, right? There's lots of aspects. Staff turnover is relatively high. It is a very stressful job. And the system is decentralized and fragmented, meaning it doesn't work well together. There are lots of small parts that work together and they're not always conducive to success. We also have a lack of licensed providers in rural and low-income counties, and again, a lack of cultural competence among providers. Government policies in mental health care. Following the deinstitutionalization, the government's role in funding and policy became substantial. So now the government provides much funding for mental health care. This is mostly done through Medicaid. We also have the Mental Health Parity and Addiction Act of 2008. And this is a concept of equality in healthcare coverage for people with mental illness and those with other medical issues or injury. The Affordable Care Act of 2010. Medical coverage for individuals with mental disorders grew. Individuals with mental disorders disproportionately benefit from coverage expansions. They tend to have lower incomes and are less likely to be insured, so therefore they benefit the most. Some communities may lack infrastructure to adequately meet the needs of newly insured individuals, though. For the end of this lesson, here are some questions to think about. How can community mental health centers work to reach 100% of their territory in need? What role can schools play in supporting mental health in children and adolescents?